This voiceover is for the second portion of the endocrine content. It's going to cover thyroid disorders. Issues with thyroid function are one of the most common endocrine disorders. The thyroid hormones T4 and T3 regulate energy metabolism as well as growth and development. Disorders of the thyroid gland include goiter, benign and malignant nodules, inflammatory disorders that lead to hypo and hyperthyroidism. With hypothyroidism, the client will have low thyroid hormones, or T3 and T4. The anterior pituitary gland will then release TSH, which will prompt the thyroid to make more T3 and T4. With hyperthyroidism, it's the opposite. You'll have too much T3 and T4 and a low TSH. Goiter is an enlarged thyroid gland. The thyroid cells are stimulated to grow, which may result in hyper or hypothyroidism. The most common cause of goiter is a lack of iodine in the diet. In the United States, most people use iodized salt, so the cause of goiter in the US may be due to certain foods or medications which contain thyroid inhibiting substances. Non-toxic goiter is a diffuse enlargement of the thyroid gland that does not result from cancer or an inflammatory process. Normal levels of thyroid hormone are associated with this type of goiter. If the goiter is associated with hyperthyroidism, it's considered toxic. This type of goiter is often found in people with Graves' disease, which we'll talk about shortly. TSH and T4 levels are drawn to determine whether the goiter is associated with a normal or abnormal thyroid function. Thyroid antibodies show the presence of inflammation in the thyroid. Clients who have goiter will present with visible swelling in the neck, as shown in the image, and treatment consists of intake of iodized salt and surgery. Hyperthyroidism is hyperactivity of the thyroid gland with sustained increase in the synthesis and release of thyroid hormones, or T3 and T4. It occurs more often in women than men, and it often occurs between the ages of 20 and 40 years old. The most common form of hyperthyroidism is Graves' disease. The most common cause of hyperthyroidism is Graves' disease. This is an autoimmune disease characterized by diffuse thyroid enlargement and excess thyroid hormones. Lack of iodine, smoking, infection, and stress may interact with genetic factors to cause Graves' disease. The disease is characterized by remissions and exacerbations with or without treatment. With progression, there may be damage to the thyroid tissue, which results in hypothyroidism. The client may have additional autoimmune disorders. Other causes of hyperthyroidism include toxic goiter, thyroiditis, excess iodine intake, pituitary tumors, thyroid cancer, or CT scans that utilize contrast media. Diagnostics for hyperthyroidism consist of a history and physical, thyroid function tests, thyroid antibodies, a radioactive iodine uptake test. This test can help to distinguish Graves' disease from other forms of hyperthyroidism. A fine needle aspiration biopsy to rule out malignancy. A clinical manifestation of hyperthyroidism is protrusion of the eyeballs, so the client may undergo an eye examination. And the client may also have palpitations or dysrhythmias, so a ECG may be necessary. Symptoms of hyperthyroidism are related to the effect of excess circulating thyroid hormone, which directly affects metabolism and the sympathetic nervous system. Clients with hyperthyroidism may present with a variety of clinical manifestations. The most common ones can be found on this slide. Radioactive iodine therapy is the treatment of choice for most non-pregnant adults. It damages the thyroid tissue, thus limiting thyroid hormone secretion. It may take up to 3 months to see results. For this reason, the client is often treated with antithyroid medications before and for 3 months after starting radioactive iodine therapy treatment. Many clients have post-treatment hypothyroidism, which results in the need for lifelong thyroid hormone therapy. As the nurse, you must educate the client on signs and symptoms of hypothyroidism. Side effects of radioactive iodine include dryness and irritation of the mouth and the throat. When undergoing this treatment, the client should be educated to avoid exposing family or friends to this treatment. Propylthiouracil and methimazole are first-line antithyroid drugs. They inhibit thyroid hormone synthesis. Propylthiouracil is given if the client is in the first trimester of pregnancy, is intolerant to methimazole, or needs to achieve a euthyroid state before surgery or radiation. Symptoms improve usually within 1 to 2 weeks after the start of the treatment. Medication compliance is crucial, as stopping the medication abruptly can lead to the return of hyperthyroidism. Iodine is used in combination with other antithyroid drugs to prepare the client for a thyroidectomy. Rapid administration of large doses of iodine inhibits T3 and T4 and blocks these hormones from entering the body's circulation. It also decreases vascularity of the thyroid gland, which reduces the risk of bleeding with surgery. Over time, there is a reduction in therapeutic effect, so long-term use of iodine is not recommended. Iodine can be mixed with water or juice. Using a straw decreases the risk of developing staining on the client's teeth. Side effects of iodine toxicity include swelling of the mucosa, excessive salivation, nausea, vomiting, and skin reactions. Supportive therapy includes managing symptoms, reducing stress, and encouraging a high-carb, protein, and calorie diet. The client should stay away from high-fiber foods as their GI tract is already hyperactive. And the client should also avoid caffeine due to insomnia. Beta blockers are used for symptom relief. Propranolol is used to decrease symptoms such as tachycardia, nervousness, irritability, and tremors. It can be given with other antithyroid medications. Atenolol is another beta blocker that can be used. It's recommended for patients with asthma or heart disease. On the next slide, we'll talk about thyroidectomy. Subtotal thyroidectomy is the preferred surgical procedure. It involves removing 90% of the thyroid gland. Thyroidectomy is used for patients with a large goiter causing tracheal compression, lack of response, or an allergy or intolerance to antithyroid medications, thyroid cancer, or need for rapid reduction of T3 and T4. Prior to surgery, the client may take anti-thyroid medications, beta blockers, iodine to achieve a euthyroid state. Client education is needed regarding postoperative care. The client should be on a high carb, protein, and calorie diet because they're in a hypermetabolic state. They should learn ways to manage their stress levels. Postoperative care includes frequent vital signs, monitoring for bleeding, infection, airway, respiratory status, hyper and hypothyroidism. Hypocalcemia is a complication of this surgery, and it's a result of damage to the parathyroid. The client should be positioned in semi-Fowler's position post-op to reduce tension on the sutures. Ambulatory care consists of reducing calorie intake after surgery to avoid weight gain because ideally they'll no longer be in that hypermetabolic state. Adequate iodine intake to promote thyroid function. Follow-up appointments with the healthcare provider. Lifelong thyroid hormone replacement therapy if a complete thyroidectomy was performed. And avoiding high environmental temperatures as this inhibits thyroid regeneration. Thyroid storm, also known as acute thyrotoxicosis, is an acute condition that occurs when excess amounts of thyroid hormones are released into circulation. This is a life-threatening emergency. It requires hospitalization, most likely in the ICU. Thyroid storm may be triggered by stress, infection, trauma, or surgery in a patient with pre-existing hyperthyroidism. Symptoms include severe tachycardia, heart failure, shock, hyperthermia with a temperature up to 106 degrees Fahrenheit, agitation, delirium, seizures, abdominal pain, nausea, vomiting, and coma. Thyroid storm interventions include administration of antithyroid medications, monitoring airway, breathing, and circulation, intravenous fluids, decreasing stimuli, treating the fever, and monitoring urine output. Hypothyroidism is a deficiency of thyroid hormones which causes a slowing of the metabolic rate. Primary hypothyroidism is caused by atrophy of the thyroid gland, destruction of thyroid tissue, or defective hormone synthesis. Secondary hypothyroidism is caused by pituitary disease with decreased TSH secretion. Additional causes of hypothyroidism include stopping thyroid hormone therapy, Hashimoto's disease, which is autoimmune in nature, iodine deficiency, thyroid surgery, radiation to the head and neck. It's more common in women older than 60, and goiter can also cause hypothyroidism. Diagnostics for hypothyroidism include history and physical, and thyroid function test. Earlier in the voiceover, I mentioned that with hypothyroidism, you tend to have a high serum TSH and a low T3 and T4. However, if both the T3 and T4 and the TSH are low, this indicates an issue with the pituitary gland rather than the thyroid. Thyroid antibodies indicate that there's probably an autoimmune origin. Additional diagnostics include CBC and cholesterol, as the client may have anemia and high cholesterol. Clinical manifestations vary depending on the severity and duration of the thyroid deficiency, as well as the client's age at the onset of the deficiency. Symptoms may develop over months to years, unless hypothyroidism occurs after surgery or the use of antithyroid medications. The most common clinical manifestations of hypothyroidism can be found on the slide. Levothyroxine is the first-line pharmacological treatment for hypothyroidism, and the dose is based on thyroid function tests. Client education includes signs and symptoms of hypo and hyperthyroidism, managing constipation, monitoring temperature, attending regular follow-up, avoiding sedatives, as clients with hypothyroidism tend to have an intolerance, and a low-calorie diet because clients with hypothyroidism tend to have weight gain. Myxedemacoma is seen in people with severe long-term hypothyroidism. Similar to Thyroid Storm, this is a medical emergency and requires an ICU stay. It's triggered by infections, exposure to cold, and trauma. You'll see the symptoms on the slide. Late signs of myxedemacoma would be hypotension, hypothermia, hypoventilation, which requires mechanical ventilation, altered level of consciousness, and coma. Treatment includes supporting hemodynamic status and administering IV thyroid hormone replacement medications. This is a great image that helps differentiate the clinical manifestations for both hypo and hyperthyroidism.